Hi, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I'm the Senior Manager of Clinical and Educational Programs at Osteoporosis Canada. I will be your moderator for today's healthcare provider webinar on X-linked hypophosphatemia. Before we begin, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Nishnabek, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. At Osteoporosis Canada, we educate Canadians about bone health, including healthcare professionals and their clients. We are the only national organization serving people who have or are at risk for osteoporosis. We are excited about today's presentation, which will provide information about X-linked hypophosphatemia. It is not intended as individualized health advice. If you do have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many as we can, time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. Without further ado, it is my pleasure to welcome our speaker today, Dr. Angela Cheung. Angela is a professor of medicine, the K.Y. and Betty Ho Chair in Integrative Medicine at the University of Toronto, and Senior Physician Scientist at UHN Network. She is the founding director of the Osteoporosis Program at the University Health Network and the founding director of the Center of Excellence in Skeletal Health Assessment at the University of Toronto. She has won many research, teaching, and mentorship awards over the years, including the 2024 ASBMR Gideon Rodin's Membership Award. She currently holds a Tier 1 Canada Research Chair in Postmenopausal Musculoskeletal Health. And Dr. Cheung is a past chair of Osteoporosis Canada's Scientific Advisory Council. She is a current member of the International Osteoporosis Foundation Council of Scientific Advisors and the president to the board of directors for the International Society of Clinical Densitometry. She's published over 250 peer-reviewed manuscripts and has an H index of 75. Her research interests are in postmenopausal osteoporosis, atypical femoral fractures, and rare bone diseases. Please join me in welcoming Angela.
Thank you, Kerry. So thank you for inviting me to speak on XLH or X-linked hypophosphatemia. So let me see if I can share my slides. So can you see this? Okay, all right. And what I'm going to do is, so before I start, let me just see if I can start. Oh, no. Okay, let me just see. Try again. Okay, let's try this. So before I start, just want to let you know that I have served as a consultant for Kiowa Kirin, which is a company that is currently marketing one of the drugs for XLH. So I'm hoping that after this session, you will be able to understand what XLH is, be able to diagnose patients with XLH, and also treat patients with XLH. So what is XLH? It is a rare genetic disorder that affects bone and teeth, and it's really characterized by low phosphorus levels in the blood with isolated phosphate wasting in the kidneys. It occurs in 1 in 25,000 live births. So these are X-ray images of children with XLH, and they often have short stature, they have bowed legs, or what's called genu varum, or knock knees, which is on the right, and it's called genu valgum. You can also see that there's like partial fraying and irregularities of the distal, femoral, and also the tibial, proximal tibial growth plates. And these children often will have sort of delayed growth velocity and also dental issues as well. So this is actually showing you ABC is the same patient. At 5 years old, you can see the abscess. So they can form spontaneous abscess. And you can see that there's no trauma, no caries, and but they have these spontaneous abscess. And you can also see that this is him at age 7, same patient. At this time, he had maxillofacial cellulitis, secondary to spontaneous necrosis of the left temporary canine. And at age 8, this is a panoramic kind of picture of all the teeth, and you can see temporary teeth and permanent teeth with mixed dentition. Usually they have a normal enamel layer, but maybe slightly thin. But you can see the translucent dentin layer, and the enlarged kind of like pulp chamber, and very prominent horns or pulp horns. So these are what is called pulp horns. That's very characteristic of XLH. Down below is a 49-year-old woman who was diagnosed at age 4 and basically was on phosphate and vitamin D supplements until age 16 and then stopped. And then, because of various reasons, had to resume at age 40. And then after 4 years, switched to burosumab and has been on burosumab for the last 5 years. And again, on the left, in figure E is actually a panoramic radiograph of this patient, showing generalized alveolar bone loss. And you can see the various fillings and root canals because of dental infections. So these are quite common in this population. So XLH is because of pathogenic variants in the FEX gene. And the FEX gene is actually carried on the X chromosome. It can affect both men and women. And currently there are over 700 variants, pathogenic variants, that have been identified with the FEX gene. And if you sort of look at this, so if a guy carries the mutation, genetic variant, can pass it on to the daughter, but not to the son, because you can see that the Y chromosome is passed to the son, whereas the X chromosome can be passed to the daughter. Whereas if you have a woman having XLH, can pass 50% of chance passing to the daughter and 50% chance passing to the son. And so family history is really important in diagnosing XLH, although it can be a de novo mutation, meaning both parents actually didn't have any genetic mutation, but the newborn can have a genetic mutation in the FEX gene. So this is a simplified version of explaining what happens when you have such a mutation. You increase your level of FGF23. You can think of this as the phosphate hormone. It basically regulates the metabolism of phosphate in our systems. And so the increase of FGF23 is will bind to the receptors in the renal tubules and increase the excretion of phosphate. And so that's why it's called phosphate wasting. It's because you waste all the phosphate that you may be absorbing from your gut. And that's why you'll result in a low serum phosphate. So how can we, how is XLH diagnosed? How can we diagnose it? It is pretty straightforward. You can do a fasting blood draw and you do a 24-hour urine collection. Now, this is in adults, and I should have sort of prefaced this saying that I'm mostly an adult physician, and I see occasional kids, but I'm mostly a adult bone specialist. And so we try to do fasting blood draw partly because there's a circadian rhythm with phosphate. It's lowest in the morning and highest in the evening. And certain things can also decrease it. For example, if you're eating, it shifts it to into the cells. And so glucose ingestion, insulin, muscle activity, and even hyperventilation can decrease phosphate levels. It's also lowest in adults and highest in sort of in infants. And so that's why there's also an age-adjusted thing with phosphate level. And you can understand that, children needs phosphate to grow because it's in bone. It's actually in every single cell in your body. And whereas actually there's often a negative balance in the elderly because of bone loss. So when we, do a fasting blood draw, we want to look at calcium phosphate creatinine and ALP, alkaline phosphatase, and bone-specific alkaline phosphatase and PTH. And then the 25 and 125 dihydroxy vitamin D. Now, if you have access to FGF23, great. You can measure that as well. But I know not everyone has access to FGF23. And you also want to collect a 24-hour urine, and I know it's difficult in kids. So I do know my colleagues in the pediatric world will do just a spot urine. And there's some correlation between spot urine and 24-hour urine collection. But in adults, I usually do a 24-hour urine collection for urinary calcium, phosphate, and creatinine. And really, you want to calculate the maximal rate of renal tubular reabsorption of phosphate that is adjusted for GFR. So this is the TMP GFR, and this is the formula: plasma phosphate minus urinary phosphate times the ratio between plasma and urine for creatinine. And so you don't have to remember this formula. It's if you put in TMP GFR slash GFR, there are actually a lot of web calculators. And I usually actually use one of those. I tend to use the Australian and New Zealand one, but you can use any of those. So it's quite easy to do on the web, and no need to remember the formula. So of course, you also need to do a clinical evaluation, do a family history, figure out, what their issues are. It can have, people can have osteoarthritis, people can have early spinal degeneration and spinal stenosis. People can have neurological issues like headaches, because as kids were growing, often we see craniosynostosis, where the head is a bit misshapen and can sort of cause headaches and other things as well. And of course, looking at bones and teeth, and need to do a radiological assessment as well. And I would say that the clinical evaluation needs to do height, weight, BMI, plus the blood pressure as well. So these are some of the things that we should pay attention to. So who should be screened for XLH? So in children and growing adolescents, we do look for, people who have clinical biochemical and/or radiological signs of rickets. The kids with impaired growth velocity. And of course, you want to have a low serum phosphate and isolated renal phosphate wasting. And in the absence of sort of vitamin D and calcium deficiency. And often it's the telltale sign is the family history. In adults and adolescents with fused growth plates, if they have lower limb deformities, you have to think about sort of this issue. And it is the most common genetic cause for low phosphate and isolated renal phosphate wasting. You can, you should look for, signs of osteomalacia, like if someone has pseudofractures, and dental abscesses, and also and I can never pronounce this word, enthesopathies. So this is inflammation of the ligament and tendons at the insertion point. So they often have pain. And obviously this is in the context of low serum phosphate levels and renal phosphate wasting. And then once you actually suspect that this may be XLH, you should confirm it by genetic testing. But I do want to raise that, there are many causes of low phosphate with renal wasting of phosphate. Even genetic disorders, there are many. So this is a list of them. Unless you're in a specialty clinic, you may not have come across like autosomal dominant hypophosphatemic rickets, which is actually ADHR, which is actually the abnormalities on the FGF23 gene. And there's also an autosomal recessive version, which is ARHR, which involves the DMP1 and ENPP1. Now we actually have enzyme replacement for ENPP1 abnormalities. And other causes, genetic causes like McCune-Albright and hereditary hypophosphatemic rickets with hypocalciuria. And so you can see, and also Fanconi syndrome as well. Other than the genetic causes, there's also acquired ones as well. And tumor-induced osteomalacia is one of the ones that we do see in the specialty clinics, and hypophosphatemia due to renal transplantation is another one that we see a lot in sort of the tertiary, quaternary transplant centers. So I like to use this algorithm for diagnosing XLH. Starting with, does the patient have rickets or osteomalacia? Do they have metabolic acidosis? If they do, you have to think about kidney disease and renal tubular acidosis. And if they don't, and they have a low serum phosphate, then you have to look at PTH levels. Do they have high PTH levels? If they have high PTH levels, you have to think about sort of abnormalities in vitamin D metabolism or calcium deficiency, as well as primary hyperpara. If they don't have high PTH levels, then and they have low phosphate, and they are spilling phosphate in the urine, then it goes down here. But if you actually have low urine phosphate, there are other reasons that may cause that. Once you have the low serum phosphate, have rickets or osteomalacia, and have sort of a high urine phosphate level, then you have to think about, are you is this isolated renal wasting, or actually the person is wasting other things like glucose, amino acid, and low molecular weight proteins. If they are not isolated, then you have to think about Fanconi syndrome and various causes of that. Once you determine that it's isolated renal phosphate wasting, then you have to look at the calcium and vitamin D level and FGF23 level if you have it. And so if they are not high in sort of if they're not wasting calcium, and if they don't have a high 125 dihydroxy level, and they have a high FGF level, then you have to think about is it XLH or is it one of the acquired ones like tumor-induced osteomalacia or alcohol-induced FGF23 syndrome? And when you actually send for genetic testing, I would suggest that you not only send for the FEX gene, but all the potential hypophosphatemic genes as well. So what are the treatments of XLH? So phosphate is found in many foods, seafood, fish, shrimps, and other seafood, eggs, steaks, and beef. But it's also found in plant-based sources like sesame seeds and pumpkin seeds, in nuts, cashew, Brazil, nuts, and almonds, dried beans. It's also found in mushroom and garlic. Usually, our consumption is about 20 milligram per kilogram per day. So if you are, 70 kilogram person, then the expectation is that you consume about 1.4 grams of phosphorus a day. But the problem is you can't absorb all of it. Even in normal physiology, we absorb about maybe around 64%, so less than a gram. And certainly in patients with XLH, food is not enough. And so what we do is we give activated vitamin D, calcitriol, and phosphate supplements, either from Sandoz or Novartis. Those are the two that I use most, and has been the mainstay of treatment for XLH. Until fairly recently, that there's a drug. And so the reason why we have been looking for better options is because there are adverse effects of phosphate and active vitamin D supplements. There are GI side effects, nausea, vomiting, abdominal pain, constipation. You can get kidney stones. You can also get hyperparathyroidism. And the more important piece is that because when you take phosphate, it peaks and then it comes down. And so you have to take it multiple times a day. And so often that results in poor adherence. So more recently, there is a recombinant human IgG1 monoclonal antibody called burosumab against FGF23. So it binds to the high levels of FGF23 so that they don't bind to the receptors in the renal tubules so that you reabsorb phosphate and not waste all the phosphate. This is a simplified version. I'm happy to show the more complex one because what happens is that in regulating phosphate or phosphorus, it is really a combination of parathyroid hormone, 125 dihydroxyvitamin D, and FGF23, although FGF23 is probably the most important player in this. So burosumab is a sub-Q injection in children. It's given every 2 weeks. Some do give every 4 weeks, and at a dose of 0.4 to 0.8 milligram per kilogram. In adults, it's 1 milligram per kilogram every 4 weeks. You can inject it in the arm, in the thigh, in the lower abdomen, and the maximum dose is 90 milligrams each time. So I want to go through some recent trials. This is the phase 3 trial for adults published in 2018. So it's a randomized double-blind placebo-controlled phase 3 trial evaluating the efficacy of burosumab in adults with XLH. And it's the primary analysis, which it ends at week 24. So let me just... So it included adults, age, let me just go next, age 18 to 65 with low phosphate level and low TMP to GFR ratio, less than 0.8 as well. And also has a pain score, BPI pain score that's greater than 4 or greater. And so you can see over the 24 weeks, placebo is in red, blue is burosumab. You can see that the serum phosphate, whether it's at the midpoint of the dosing interval or at the end of the dosing interval, it's higher than placebo. And you can look at the renal reabsorption of phosphate on this side, and it's reabsorbing more. And also active vitamin D as well. 125 dihydroxy D levels are higher than placebo. And so this is the pain score, PPI pain score, and you can see that the change from baseline in terms of the worst pain, burosumab group actually had better results in terms of pain, improved pain control. And also when you look at the WOMAC physical function and stiffness, the burosumab group is doing better than the placebo group. So I think more important is fracture healing. So often we have people who have not sort of, non-healing fractures. And so this is comparing the two groups, burosumab versus placebo. In week 12, there's already a difference, and then week 24, there's a difference as well. This is the pseudo fracture healing in a 38-year-old woman treated with burosumab. You can see, even though there's a rod in, there's a pseudo fracture right there on the medial side, and this is healed at week 24. I also want to show the bone formation and resorption markers as well. You can see that P1NP, the bone formation marker, is increased compared to placebo group, and CTX is the bone resorption marker, is also increased over this period of time compared to placebo group. And the important thing is also to look at adverse events, and there are adverse events between the two groups. Burosumab group is on the left and placebo is on the right. Any adverse event is quite similar, but if you look at sort of back pain and headache and nausea, it is slightly higher. And also, but the arthralgias and pain in the extremities are lower, and even oropharyngeal pain is lower. There are injection site issues, similar in the two groups. And you can also see that, restless leg syndrome is a little bit more in the burosumab group. Serious adverse events are the same between the two groups, and actually they were thought to be not related to the treatment intervention. Then I want to sort of, even though I'm an adult physician, I want to share with you sort of some of the children's data. So this is the phase 2 trial, sort of that Thomas Carpenter did in 2018, published in the New England Journal, looking at burosumab therapy in children. It is an open label phase 2 trial, involved like 52 people, and it involved children aged 5 to 12 with a Tanner stage 2 or below. So this is pre-pubertal. And they also have to have a Thatcher-Ricketts severity total score that is scored, and that's the primary outcome. Is really to trying to see if these patients actually improve on the Ricketts severity score. So that's a clinical score. And facts, they all have to have genetic sort of linkage to the FACS gene. So you can see from this that these are so small study, and these are sort of like mean age of about 8 years old. I won't go over all the details, but the two groups are fairly balanced. I think this is the part that I sort of want to show you. This is the Thatcher-Ricketts severity total score. You can sort of see at baseline, and then how it dropped over time as well. So there are, in this study, they tried every 2 weeks and every 4 weeks. And so that's why the results are presented that way. But I think they're fairly similar. So you can concentrate on the end. So the Ricketts severity score dropped over time. And here as well. And then they also looked at radiographs, radiographic global impression of change score. And when you look at all patients, really not a big difference. And there's really a lot of overlap. Now, but this is a small study though. So, but those are the results. This is one of the radiographs of the knee in an 11-year-old girl, looking at sort of basically the distal femur is the knee x-rays. So we usually do wrist and knee x-rays for children, and looking at growth plates and distal femur, proximal tibia. And so you can see at baseline, week 40 and week 64, that the knee sort of Ricketts severity score went down, and also the radiographic global impression of change global score improved as well. So that's sort of this is just to show that there's improvement when children went on burosumab. Serum phosphorus level. So every 4 weeks is the one that is in green. Every 2 weeks is in blue. So you can sort of see the sawtooth pattern of this. And then this is renal tubular phosphate reabsorption. And again, it's a sawtooth pattern for every month, every 4 weeks, compared to the blue in every 2 weeks. It's partly because of these data. This is serum 125 dihydroxy-D. It's partly because of these data that people are suggesting in children think about doing every 2 weeks rather than 4 weeks. And this is serum alkaline phosphatase levels. When you treat them, their serum alkaline phosphatase will come down. So with that sort of phase 2 trial, there's a phase 3 trial. And this one is burosumab versus conventional therapy. And it's an active control open label phase 3 trial. And what they change is that they change the age. They now extend it based on that phase 2 trial. They now extend it to from age 1 to 12. And they're looking for a Thatcher-Ricketts severity score of greater than or equal to 2 for this trial. The fasting phosphorus has to be low, less than 0.97. Need to have a linkage to the FAX gene mutation, needs conventional therapy for at least 6 to 12 months, depending on the age. And the 40-week is the primary endpoint. Now, this time they use the radiographic global impression of change global score, but the full trial is 64 weeks. So you can see 122 people were assessed and 61 were randomized. This was published in 2019 in the Lancet. So these are the outcomes. So as I mentioned, this is the primary outcome and 40 weeks of the primary outcome. And so you can see the difference between burosumab versus conventional therapy. And at 64 weeks, it's maintained as well. There's a lower limb deformity score as well that, and you can see that there's a difference between conventional therapy and burosumab. And also the Thatcher-Ricketts severity score, you can see that there's improvement with this score at 40 weeks and also at 64 weeks. And when you actually look at alkaline phosphatase, it decreases. So burosumab is in the blue. It decreases over time, whereas conventional therapy, it stays about the same. Just want to show you sort of wrist and knee radiographs of a 4-year-old girl treated with burosumab. This is at baseline, and this is at 40 weeks. And you can sort of see that, you know, visually there's a difference between the bones, right? So, and also this is the knee. And again, you see flaring and also irregular growth plates as well. And this is at 40 weeks. And so, all of these, whether it's the radiographic global impression of change or the Thatcher-Ricketts severity score, they improved over time. What about the biochemical markers? Yes, it can increase serum phosphate. And it increases 1,25-dihydroxy D and also improves the renal tubular reabsorption of phosphate as well. So it does all of those 3 things. And this is in relationship to normal range. The dotted lines are the normal ranges. So just for your reference. And I think, you know, physicians concentrate on clinical outcomes. So height and mobility were assessed. So height was the length, recumbent and standing height as well. And you can see that burosumab actually is a little bit better, but not statistically significant. And the 6-minute walk test as well, it's a bit better as well for the burosumab group. There are treatment emergent adverse effects, fairly similar to sort of the adults. Injection site issues is one, and you can sort of see in kids, you can also get fever, cough, arthralgias, and GI side effects. So vomiting, diarrhea, and various GI side effects as well. And also a splatter of various other symptoms. What about patient-reported outcomes? So for those children who are age 5 and over, so there are 35 of those, they were asked to fill out these patient-reported outcomes. And they used the PROMIS pain interference score. You can see they use also the fatigue score. And you can see that actually Burosumab does better for pain interference, actually decreases pain interference and fatigue, um, and um, and improve the physical function mobility score. You can see that here. And then uh, as part of the patient-reported outcomes, they also did SF10. So this is the short form 10. So it's similar to the SF36, but shorter, and it's mainly for kids, looking at physical health and also psychosocial health. And the burosumab group did better than the conventional therapy group for both of these issues. And then I want to share with you the extension of this phase 3 trial. So it's actually published in JBMR Plus last year, 2024, led by one of our own, Dr. Leanne Ward, looking at burosumab versus conventional therapy and looking at the extension. And so this is looking at like from 64 weeks to 88 weeks. It is a longer duration, and it's looking at age 1 to 12. And so there are 21 patients in here, 6 are continuing, and 15 are crossover. We can look at sort of these two groups. So the crossover ones are in the gray. So you can sort of say conventional therapy changing at 64 weeks to burosumab therapy compared to those who continue on burosumab. And this is the radiographic global impression of change in the Ricketts score. And this is the severity score. Again, sort of this is um, uh, the group that changed, and then the burosumab group in the black. If you look at specifically at the lower limb deformity score, you can see the improvement on the on the crossover one, and also continued improvement from 64 to 88 weeks as well. And then the crossover group actually used 0.8 milligram per kilogram every 2 weeks. So just want to mention that because they were testing at different doses. I want to show some pictures because sometimes it's easier to see it. Often I'm a very visual person. So this is the continuous burosumab treatment person. It's 2.9-year-old girl, right knee and left knee. And so you can see like from, baseline to 40 weeks to look at this, right? 64 to 88 weeks. And again, like look at the left bottom one as well, like baseline, look at the bottom side as well. It really has improved over this period. And then if you look at the conventional therapy up to 64 weeks and then switch over, you can definitely tell a difference between these images and the one on the right. This is in a 3.5-year-old girl who switched from conventional therapy to burosumab therapy. And if you look at sort of the leg deformity, this is burosumab continuation over the 88-week period, so about 20 months or so. You see that it has improved from a very bold kind of configuration to a little bit more straight. There are still some abnormalities. And then you can see this is a conventional therapy one that switched to burosumab, and you can see that the difference between this and this, which is sort of more less impressive. And if you compare as well, certainly height and recumbent length set scores, there's improvement up to 88 weeks, and growth velocity as well. There's improvement, and also the 6-minute walk test as well. Maybe sort of it's a little bit less um, easy to detect in the 6-minute walk. But often, if you ask children and parents, you will hear that they say it's that there is improvement in their gait and mobility. Now, I want to end and allow for some discussion as well with the guidelines. So these are fresh off the press, January 2025. These are your European guidelines endorsed by the International Osteoporosis Foundation, the ECTS, and many other European pediatric organizations as well. So the guidelines recommend treating children and adolescents from 1 to age 17 with signs of rickets with burosumab. And those who are older, 18 and adults, suggest treating with burosumab if they have pseudofractures or inadequate response to phosphate supplement and calcitriol. So those are the recommendations from the group. And I want to show sort of their recommendation for follow-up as well. So in kids who are younger, it's more frequent follow-up, like 1 to 3 months. And as they grow older, say 5 to 9 to 12, it's like 3 to 6 months. Over puberty, it's every 3 months. And then in adult care, we usually see them 6 to 12 months. And it has good suggestions for what should be done at the visits, like hearing tests, dental exam, and blood tests and urine tests, blood pressure, renal ultrasound, and depending on the situation, fundoscopy and brain MRI and spine MRI. So those are some of the things that are suggested as good practice, good clinical practice. So to summarize, XLH or X-linked hypophosphatemia is a rare genetic bone condition diagnosed with blood and urine tests plus genetic testing. And we used to treat it with phosphate and vitamin D. We still do because access to burosumab is not great. But burosumab, which is an FGF23 antibody, monoclonal antibody, is the new treatment. And I'm happy to answer any questions. Oh, resources. So there are resources on Canadian XLH network, at CARDS, which is the Canadian Alliance for Rare Disorders of the Skeleton, also at the Canadian Consortium for Children's Bone Health, and Osteoporosis Canada developing some resources as well. So thank you for your attention, and below is my email. Thank you.
Thanks, Angela. That was great. So much information for everyone to think about. I now want to turn to the question and answer period, and we'll do our best to get to as many questions as we can. We've received a few. So let's start with this one. Do you treat all XLH adults with phosphate and vitamin D or burosumab?
That is a great question. It is, I would say, treating everyone is a bit controversial. There's been a lot of discussion about this. I think there's consensus that we should treat the symptomatic ones, those with arthralgias, myalgias, and various, pseudo fractures and kidney stones and other issues. We should treat with burosumab. Those who are not symptomatic, Sometimes we would give them a little break, but there's been evolving data around sort of even treating the asymptomatic folks. They have better mobility, decrease in mortality, morbidity, and other things. And so it is often a discussion with the patient in terms of whether to treat them or not. Um, Obviously, when kids are growing, we treat everyone up to maybe age 16, 17-ish, depending on whether it's a boy or a girl. Sometimes we treat longer for boys. And then in adulthood, it really depends. And it's a topic that has been controversial, I would say.
Okay, thank you. The next question is, I have a case of XLH in her 60s. She has bad osteoarthritis of her knee, and she will likely need surgery. Would you treat her with burosumab in this case?
Yeah, I would. Like if someone is having surgery, I think you need to treat. If you can get burosumab, great. If you cannot, I would treat with phosphate and vitamin D, active vitamin D. Like there are two situations where I would consider treating someone going for surgery, someone with a lot of dental issues, and someone who's pregnant. This is in the adult world. So those are the three things that I would consider treating. And obviously someone who's symptomatic. So four things.
Okay. And we have one last question. Here it is. How can the pediatric dentist best support a child with XLH, hypophosphatemia, and high frequency of dental abscesses, even with preventative and proactive care? How can I improve their life in cases where the dental effects are severe?
That's a great question. I think frequent dental exams um, and also teeth cleaning, it's probably important. But I would say, like you saw the cases that I showed, those don't have like it's not because they have a cavity and they get an abscess. So I think uh, I'm not sure there's a way to prevent, except for treating. So if you treat patients, they do better symptomatically with all these various issues.
Okay. Well, I would like to thank Dr. Cheung for such an informative presentation on X-linked hypophosphatemia. And for more information on osteoporosis, please visit our website at osteoporosis.ca. We have several upcoming events you can learn more about on our website. Here you can see, information about our nutrient calculator, OC replay, and Unbreakable, our podcasts. Um, Other things on our website include podcast quizzes and a repository of past webinars. And finally, I'd like to say thank you to all of you for joining us today and wishing you a pleasant evening. Thanks again for joining us.
Thank you.